Hello, my name is Miss Erica Brown and I am the instructor for this course. This is the first recording for the semester and it is over the overview of radiotherapy. I will record this and I will place this voice thread within Blackboard, as well as I will download the content and upload this into Notebook LM. That way you have the content in a couple different locations, as well as the content will be available for you to study and ask questions on within Notebook LM. If you have questions throughout the semester, please feel free to reach out. The purpose of radiotherapy is going to be treating pathologies, typically that's cancer, with high energy ionizing radiation. So the ionizing radiation is very similar to X-rays. We have just used an accelerator to create a higher energy version of it. There are a few pathologies that we do treat that are not cancerous. I won't explain those too in depth right now, but there are some things where a mass that's not cancerous could be putting pressure on the spinal cord, and we have to go in and use ionizing radiation to see if we can help shrink that tumor to relieve the pressure on the spinal cord. The treatments are local, meaning that we are treating the tumor or surrounding the tumor, but we're not treating if somebody has breast cancer and it goes to their brain. We are typically not treating the breast and the brain in its entirety. So we don't do, a ginormous section. We are going to be looking more at individuals. So we could treat the breast in the localization area of the tumor or where it was removed. And then we could treat the brain as like a whole brain, but we're not going to treat, all the way from the breast through the entire anatomy up through the brain, if that makes sense. So we're treating local, smaller areas. We can use this for a curative purpose, meaning that the hope is we have eradicated enough of the cancer cells that they hope that there will be no reoccurrence or a lower chance of reoccurrence. So if they reach a certain number of months or years without a reoccurrence, then we say that they are cured. We do treat palliative situations, and those are typically our patients that are stage 4. So it has traveled to other parts of their bodies. And because it has traveled, it is nearly impossible to actually eradicate every single last cancer cell. So they say that a majority of these is we are doing palliative services. One of the big things with that is brains. And so if you have breast cancer, like I mentioned, and it traveled up to your brain, and let's say that we found 15 different small tumors within your brain, that's what typically happens with metastatic cancers. You get lots of little lesions. If we found that, they are typically not going to go in and try and remove all 15 of those because that would take a lot of brain tissue. They could be in very challenging spots where they might cause damage to other structures. So they can come to radiation therapy, and we can do a treatment called a whole brain. So we can treat the whole brain, or we can kind of add some extra boosts of radiation to some of the larger tumors. And what that'll do is it will help shrink the size of the tumors. And when it does that, it can help relieve pressure that could be putting on a ventricle, or it could be putting pressure on like the thalamus or the spinal cord or the brainstem. Like there's so many things that either within the brain, the neck, or the back, that if you have pressure on them, it's going to cause issues. So we can relieve some of that pressure by shrinking the size of the tumor. But those patients with palliative, we can never truly say that they are 100% cured. So I have this umbrella term called radiation oncology. So that is similar to the word radiology. In radiology, you have your branches, right? You have your X-ray, CT, MRI, all those modalities. In radiation therapy, it looks a little bit different. So we call it radiation oncology, but we house different kind of entities underneath. So we have a radiation oncologist who is a physician. We have the nursing staff that helps take care of the patients and get their vital signs. We have us radiation therapists who actually deliver the treatment. We have a dosimetrist that will create treatment plans and double check on prescriptions from the doctor. We have physicists who will ensure the safety of the equipment and run quality assurance to make sure the machine's running and operating correctly. We have social workers who will look at the patient's scenario and see if there's any resources they can provide them with, like if they have trouble with transportation, like can they help them with public transportation or can they get somebody to give them a ride. We also have a dietitian. So those are going to be the ones that are looking at their dietary needs. And if the patient's having trouble swallowing because of pain due to a neck cancer and the treatment, how can we get their weight back up? Because we want them to try and maintain a similar weight throughout their treatment. So what resources, like what kind of foods can we give them, or suggestions for increasing their calories? So there's a lot of different entities with underneath that umbrella, but it's a very similar concept to when I use the term radiology. We have all these little branches that are falling underneath of it. Radiation therapy can also be called radiotherapy. Neither one is wrong or the correct answer. You can use it in both aspects. So I have kind of spread it out throughout the course as either being radiotherapy or radiation therapy. Either one, very much acceptable. Some history on radiation therapy is we started somewhere, and so that was with the discovery of X rays. November 8th, 1895 was when Wilhelm Conrad Röntgen discovered X rays. And then early into the 1900s, there was obviously more experimentation that was going on with the either entertainment purposes or medical treatments with X rays. So they tried to use some of these low energy units as treatment for cancer, but they found it wasn't nearly as effective as if they were to increase that energy. In 1928, they started to do some treatments with particulate radiation. And so with the particulate, there is proton and electrons out there for therapy treatments. It was introduced very early on, like in 1928, and we still use it today. It's for more of like skin treatments or like superficial tumors. And then proton therapy came quite a bit afterwards. In 1937, we finally started to see some of that higher energy that we were able to create. 1956 is when we saw the first patient that was treated in the United States at Stanford University. And so, over on the right hand side for this picture, one of the very first patients was a child that had a brain tumor. And they were using machines that looked just like this. So, in my opinion, that's a little scary looking. It would definitely make me nervous to have my child be right up next to this. Nowadays, they look more aesthetically pleasing. They're not as scary. So, and they're also much more efficient. So we don't have to worry about things as much as they did back then because there were a lot of side effects. Some basic types of radiation therapy. The most common that you probably think of is external beam radiation therapy. And so this is where we are delivering high energy photons from outside of the body and we are delivering it to inside the body. So this is the one that's most commonly thought about and is widespread types of treatments. The second type is internal beam radiation therapy, oftentimes also called brachytherapy. So this one is, I would say, not as common. And the only reason I say that is because you have to have a specialized treatment machine and a special environment because it's more of like a surgical suite many times. So where I did my radiation therapy clinicals at, they didn't even have brachytherapy as an option. They had to go to a separate facility with a different oncologist if they wanted to receive that type of treatment. What happens is we are delivering ionizing radiation within a structure. So we have to actually introduce a radioactive source within the cavity or within the tissue. So when we're doing this, the patient's going to be asleep. We're not just going to go ahead and just inject things, especially because they're not super, super small needles. They're a little bit bigger lumen that allows for the radioactive source to be implanted and then removed. Some procedures, they may just be more like lightly sedated, or they may be just numbed in the local area, depending on the invasiveness and also the where the tumor is located. So it kind of just depends, but a lot of times they are sedated. So we're using that radioactive source, and I will show you some images of what that looks like. This is going to be a setup of an external beam suite for treatment. And so what we have here, this is a particular brand. It's called Varian. This is what I learned on. I have done a lot more research on it, and Varian has always been my favorite. I mean, I might be biased since that's where I learned at, but there are some other brands out there like called like Electa. That's a brand name. It's just like if you're going to buy a car and you buy a Chevy versus you buy a Ford. They have similar features, but they are still a little bit different, right? Your shape of your body of your pickup might be different. You're going to have different subtle features within the technology, all those things. But the main point is that with Ford and Chevy, they're both vehicles and they're going to get you from point A to point B, right? Same thing with our radiation that's delivered from our linear accelerator, is what we call it. Regardless of what manufacturer you use, it's going to deliver the high energy radiation. So that way we can treat that tumor. So what you're seeing here is, I kind of have a diagram next to it, but this is what we call our treatment couch. So the black part is the table that extends out and allows for the patient to be underneath what we call the gantry. So the gantry is this whole kind of structure here that's above and below the patient. So that table, what's really nice is, I'm going to draw on the diagram, is it goes up and then it actually will push the table forward so it can be in its separate location away from the stand. And it has a lot of flexibility. So you can raise the head of it, you can lower it, you can kind of, it has some hydraulics on the inside of there where one side of the table, so right or left side of the table, can be higher than the other. You can just have a lot of different features. So here's that gantry on the diagram. We call this up here the gantry head, and that is where all of the acceleration is taking place. And then the beam will exit through right here and interact with the patient. On the sides, we have our imaging arms. So this is where the X-ray tube would be for our kilovoltage or kV imaging. And then this is the detector for that kV imaging. We also have the capability of using MV or megavolt imaging. And I have some pictures later on to kind of show you the difference between the two. But kV is more what we think of as a standard X-ray. It looks better. Of course, it's not diagnostic quality because we don't need that here. We know what their structure looks like. We're just trying to image and see where we are for the day. What is our positioning? MV is going to look a little bit less pretty than the kV. We call it a port or a portal image. It's kind of just a straight shot and it gives you an eyeball view of what you'll be treating, because when this MV imaging comes out, like it is on the actual picture here, do you see that it's opposite of the gantry head? So the gantry is what's actually providing the radiation to that detector versus the kV imaging arms have its own X-ray tube off to the side. So that is a little bit different. It doesn't look as pretty, but you have to use it for some circumstances. Also within here, and I'm going to kind of clear all that off here real quick. Over here, this gentleman is standing here, and what he's doing is he has what we call a pendant. So this pendant is a remote control, and it has a whole bunch of different buttons, like a ridiculous amount, that allows you to maneuver the table. You can maneuver your gantry. There's so many capabilities with this. You can turn the lights on and off in the room with it. There's a lot of different structures that are necessary to make things work. The same exact operation controls that are on that pendant are also found on the couch or the table. So right here is actually where our control panel will be, and it's on both sides. So you can operate anything from either side of the machine. And then the pendant is usually hung at the end of the table. So you can see that on the drawing here. We have one pendant here, and then there's another pendant over here. Some machines, manufacturers, like they only have one pendant versus two. But the majority of the ones that I have seen, there are two pendants. So this is what we call our setup for that external beam radiation therapy, and the linear accelerator is the whole unit itself. So not just the gantry, but it's the whole structure, because there's a lot of components that actually work back here in what we call our drive stand. And so that's where we're getting all of our power and how it's pushing through are electrons that will then go into our gantry. Here's a straight on view of what that gantry could look like. And what's nice about this picture is that it's actually showing you that we have multiple capabilities with that gantry. It can rotate. So this, where it would be kind of this phantom or ghost image, is when it's straight up and down. Then the current location is kind of off to the right. And then we actually can bring it all the way down here or all the way underneath the table. There's also these phantom images over here, which shows that it came from this location and from this location. So it can only rotate the 360 degrees and then it has to rotate back. So it's not like an unlimited just spin the wheel and it can continue to go. It can only make it, if it started here, it can only make itself all the way around and then the gantry head would stop here and then have to go back the other direction. But what's nice about these linear accelerators is that we can treat a wide variety of anatomy because it's so flexible. The table moves, the gantry moves. We can come in at multiple areas. And also, the gantry head is just very efficient and flexible. We can use a variety of energies to treat the cancer. So, if we need something to be a little bit more deeply penetrating, we alter our beam. If it needs to be more superficial, we alternate our beam. There's just so many capabilities. And that's the only reason that we can do that is because we have this linear accelerator. Here are the breakdown of a few different types of radiation therapy. So we have 3D CRT, which is also known as 3D conformal radiation therapy. This is done where they look at the dose and the beam changes based on the path and also the angle that it needs to come in at. And so this is using forward planning, trial and error, and it's very time consuming for the dosimetrist. Because if they say, all right, I'm going to have 5 different beams come from 5 different angles, and let's say they get through 4 of 5 and they realize, oh, well, I'm already giving too much dose to this location, or my tumor is not receiving enough dose, then they have to scrap what they've done and then restart or at least fix a couple beams. So it takes a while before they're able to create a perfect treatment plan. IMRT is called intensity modulated radiation therapy, and this is an advanced form of that 3D CRT, and it conforms to the tumor with inverse planning. So, what do we mean by inverse planning? It means that we are looking at the tumor and we give all of the structures a certain amount of dose that it can have. And then what it's going to do is it's going to break down all of the angles after we determine our dose. So it's going to basically work backwards, saying I can do this many angles to avoid these tissues and still get this much dose to certain areas. So this is much faster and it's also more efficient. We have VMAT, which is volumetric arc therapy, and this is a more advanced version of IMRT, so we're just building on it. The gantry is going to do the same thing that IMRT did, so we can have 12 or 15 different angles coming from, starting with the gantry at the bottom and then the gantry at the side, the top, the left, the right. But the thing is with this is volumetric. It means that our gantry is not going to stop. So with IMRT, it stops at every single individual beam. It says, all right, I'm moving to my location. I'm going to treat from that angle. Once that's done, I stop and then I rotate to the next location, treat, and then move to the next location. With VMAT, or volumetric arc therapy, is that we start from one location, usually at the bottom, so the gantry head's underneath the table, and it will continue and do all 12 of those beams, modifying as it goes. So it's going to start to move and it's going to go the 360-degree path without stopping and still delivering all 12 of those beams. So it takes a little bit less time. We have IGRT, which is called image guided radiation therapy. And so 3D CRT, IMRT, and VMAT can all fall under the IGRT. What this means is that we are imaging every single day, or most days, to determine the location of our structures and align them so that they're as close to possible as the day before. we want to make sure that we're as precise as possible so that we don't risk accidentally overexposing a different tissue that's healthy and causing damage there. So most treatments these days use some form of IGRT, whether they just take a generic X-ray with KV, or if they take it with the MV beam, or we also can do what's called cone beam CT. And so the CT is going to come out looking like a CT slice, and we're going to be able to identify at multiple levels that we are in the correct location compared to how we were when we simulated the patient. So precision is what we're all about, and that IGRT, its job is to help with that precision. External beam radiation therapy has a very chronological order or process. So what we will do is we'll get our patient on the table, make sure that we have the area that we need to see exposed so that we can identify we're in the right spot. We are going to find our marks, which are little crosshairs on the body, and align them to our lasers. So this first picture is showing that we have our patient on the table. They're positioned underneath the gantry. The next part is we typically turn the lights off so that we can see the lasers that come off, which are the green here. So we have a green that's running down the side of the body, one that goes across, and then we have one that runs down the center. So we'll find our little crosshair marks, which look like this, like a crosshair. And we're going to try and line up those lasers with the crosshair, all three of them. So there should be one on each side and then one on the top of the patient. Once we find that location, we know we're in a good starting point spot. So then we can take our imaging, so that IGRT. We can do our KV x-rays or MV portal images, or do an actual CBCT, which is that cone beam CT. At the console, we're going to look at the images that we just took on the patient and actually flip back and forth, back and forth, back and forth to the simulation day, the very first day that they were positioned according to what we were going to be treating. The images I took that day to the ones we just took, we're going to flip back and forth on their anatomy images and try and align them as close as possible. Once we are very, very close, if not absolutely perfect, we will then verify and the table is going to shift to the right spot. So we're talking like millimeters of accuracy that the table will be moving. Once that's in place, we know that we can start treating and the patient's in the best possible position. And so that we are not giving radiation dose or too much of it to healthy tissues. So that's kind of the basic overview of the whole process from start to finish of that treatment. But we'll go into breaking that way further down a little bit further in the semester. Other things, if you were just curious about on the skin here, this patient has this red line and little numbers on there. So that's actually a ruler, and it's a distance indicator from our gantry head. So that's very similar to when you're trying to solve for, if you're thinking about your SSD or your source to skin distance in X-ray, that'd be if you took a tape measure and measured from the source, which would be the anode, measured down to the patient's skin. This thing happens in our linear accelerator, but we don't have to use a tape measure. It just shines it on the patient. And actually, there are some fancy X-ray equipment out there that does do that. It shines down a measurement label. However, I would say in typically and out in practice with X-ray, we don't really worry too much about the SSD. We care more about the SID. So we're looking at to the detector, not to the skin. But in radiation therapy, we're not trying to image to a detector. We're imaging to look at the patient and see how far am I from the patient's skin compared to my last time. So that way I'm not treating the wrong area. So it's just another safe measure to ensure that we are delivering the correct dose and to the correct location. With our imaging, this is what our screen is going to look somewhat like. So over on this left-hand side, we have kind of a weird looking image, right? So these are CT images that are in the coronal. So this is a coronal image up here. We have our sagittal image, and then we have an axial image. And so the kind of like the pink and the green color in the background That's representing the structure of the body that we originally imaged back when they were simulated. So the very first imaging we ever did on our patient when they came to us. And so our system automatically uses artificial intelligence to create a rendering or a new picture of the patient. So that's what the green looks like, because there's still a CT behind it, but the green's just identifying that this is our original structure. So then if you see kind of the overlap, this line, the white line that kind of runs across the patient on both, like all three views, you can see that. And then you can just see how it kind of like hovers ghostly over on this axial image. That is what image we just took that day. So our cone beam can't get the whole body. So our cone beam only has a certain distance that it can cover, and that would be the diameter, is from this top location to the bottom. And so that's the anatomy that we are imaging, and we're going to overlap. So things that we want to look at, and I can zoom in here a little bit so you can see. So all of the structures that we care about, this is your aorta, and I'm going to get a different color because green over green is not helpful, right? So this is your aorta right here. So that is one big structure we can look at. We have up here kind of where our sternum meets our clavicles. We can use that. We can look at the arm positioning, and you can actually see how the pink and the green and the white that's underneath of the bone don't all overlap. That means that that patient's left arm is in a different position than the very first day that we imaged. Over here, they overlap fairly well. They're still not perfect, but that's okay. Our tumor actually is right here that we're trying to image and overlap. So we're going to look at this. We can see where the lung volume is. We're trying to overlap all these structures in every view. So we'll flip back and forth from the old to the new and trying to outline where that tumor is. And you come down to the axial, again, you can see where that tumor is. And we're trying to get it as close as possible before we actually treat the patient. Then over here is what we call our console. Our console is what we actually can deliver the radiation through. And so I'll zoom in here again. So we do have some capabilities, like, so we don't have to always get our imaging arms out before we come to the console. So let's say you forgot to use your pendant and open up your KB imaging arms for your CT. That's okay. Guess what? We can do that from here. So your buttons up here are all about your imaging arms. So your KV and your MV. So I'm sitting at my console, my patient's on the table by themselves in the room, and I can press the button and hold it, and it will pull them into place. So I don't have to go back in the room and fix it. So that's really nice. It is very slow, though, I will say, when you do it from the console, kind of as a safety precaution, so you don't accidentally hit something like the table or the patient. Over here, we do have where you can increase the audio, the sound from the patient. So if you're curious, like if you thought that they said something, you can increase the volume. You also have this push to talk with Varian, so that manufacturer allows you to hit that button and it will actually project your voice into the room. Occasionally, we do have to have them hold their breath. And so with that, you're going to have to hit the button and tell them because you're not in the room with them. Another thing is that over on this side, we have our prepare button and then our KV ready and then our MV. So what happens here is when it's ready to go, so ready to do our CT, it's going to light this button up. It's going to say prepare. So I'm going to hit that. Once I hit that button, then it's ready to go and my CT, my KV is ready to go. So I'm going to hit this button once it says it's ready, once it glows. And when I hit that, then it'll start the CT. It's same thing if you're doing your KV, just regular x-ray. If you're doing your MV, it is different. So you're still going to have your prep button you're going to have to press, but then your MV beam is going to have to be touched right here. So you're going to have to hit that for it to image for a portal image, so from the gantry head. Same thing then after you get everything ready to go and you are prepared to treat. It's going to have that prepare button ready to go at the top, and then this is your last safeguard. You have to hold the prepare button down and hit the beam on MV button at the same time for it to truly start its actual treatment. That's your last chance before you could make a possible mistake. So definitely don't want to have that occur. So it gives you those last minute things. If you ever have an issue where you're like, oh my gosh, we need to stop, emergency stop is right there. So hit that quickly. The only thing that stinks is it kind of like shuts down your machine a little bit, like not completely off, but pretty darn close. So it's going to take a little bit for it to come back up. So unless it's an emergency, don't hit that. Instead, you can hit this beam off button. So if it's just a little, oh, I think they kind of just coughed a little bit, I can hit that and it'll stop it for a second. And then if I think they're good to go, I can hit this again to start. But if it's a really bad scenario, patient's throwing up and, they're like about to hit their head and everything, we can hit this emergency stop and run in there. And then another thing is that we can also start moving the patient down if we need to as well. External beam using electrons is something that we do use in rad therapy, and it's more for skin cancers or for superficial tumors. And so when we do this, we actually have to add a secondary cone or device to our gantry head. So you can see that here. On the bottom of the gantry head, there's going to be a little location where you can clip in this holder. Then you're going to have a cone. We have a few different sizes that will slide directly into that attached portion. Okay. So why does this matter? Because we're not going to use our normal collimation tools with the gantry head. What we're going to use is we call them electron blocks. And so what happens is you pick the size of your electron block, basically, depending on how big the cancer is. So let's say this patient has this type of cancer and it's this large. So what we're going to do is we're going to create this block. We have this metal outside container, and we are actually going to create our own molds of what the size and the shape of that tumor is. So how do we do that? It's actually really cool. This is something that I never knew existed in rad therapy until I was already in school. So this was really new and kind of interesting to me. So what we do is we take, again, that metal outside container. You are going to place it up within the tray, and there's a little glass panel that's sitting inside of that tray right now. And then you're going to shine the light from the gantry that is inside of here. You're shining the light down the patient, and you're going to bring a Sharpie onto this glass, and you're going to draw over the shape of the tumor that's hovering above the patient. So you're still a couple inches away from the patient's skin, and you're going to use a Sharpie and use your shadow of that Sharpie to help guide you around the shape of the tumor. Once you have that, we get to go create the true block. The first thing you do is you're going to take a piece of paper and you're going to draw that same shape that you already had on the glass on the paper. Then you're going to poke some holes in the paper with a piece of styrofoam underneath it. So this blue chunk right here is a piece of styrofoam. And what I had done was I had just taken the end of a pen or whatever you want to use that's a little pokey, and I poked out, traced the outside of the paper that was this same size. Then, once I kind of have my outline, I take the paper off. You're going to use a styrofoam cutter. So it's like a hot wire. And you are going to guide the styrofoam into the hot wire. It's kind of creative. You got to kind of have some good dexterity there. And you're going to cut off the outside that you don't need. So when you cut off the outside that's surrounding that traced area, you're going to be left with a couple inches thick of foam that's in the shape of the original tumor. Okay. Then here's really where it got tricky for me that I was really surprised about. You are going to have a pot of molten metal, literally liquid metal, and we would call it BLT with cheese. Okay, so now it sounds weird, but it helps you memorize the metals that are actually liquefied inside of this pot. So it's bismuth, lead, tin, and cadmium. So that BLT with cheese. And so the outside of the pot is going to have a little spigot, just like it would if you were getting a lemonade out of like a little lemonade stand, like the jars that you can pull the little spigot and it pours out the lemonade, just like that. But you're going to have a cup that you'll put underneath this pot of liquid metal, and you're going to open the spigot, you're going to pour it into the cup, and then the cup, you're going to pour it around the shape of that styrofoam. And you're going to fill it up until it reaches the top of that mold. So it would reach the entire outside here. So, I mean, I would say it's like a few, a handful of millimeters thick, but it gets heavy because of the metal. It gets really heavy. So then you're going to let it sit. Usually we would let it sit for at least 24, if not 48 hours to make sure that that liquid metal was good. And so then we would break out the styrofoam block from the center. You just kind of pull it apart in chunks. When it's gone, you get this. So it's what we call an electron block. And then you put that in the bottom of the cone. And so then every time your patient comes in for treatment, you'll set up the cone, you'll put the block inside of it. And then when you shine the light down, the light's only going to go through this open hole or the shape of the tumor. So it's going to go right over the skin cancer. So that was something that I definitely did not know about before starting rad therapy school, but it was something I actually enjoyed because I got to work with my hands a little bit just differently, had a little bit of a creative aspect to it, and the molten metal was cool. Obviously, because it does have some serious metals, especially lead, you need to make sure that you're careful with it. You don't want to burn yourself, and lead is not good. So we always had special soap when we were leaving that room. It was called lead out soap. And so it kind of reminds me of like the really grimy, gristly orange soap that like mechanics and stuff use to help get like grease and oil off their hands. Um, that's what we would use, but it has a special material in there to help get rid of the lead. And so that made it a little bit more safe for us, but definitely something that was interesting to me. Another kind of external beam radiation therapy that we can use is a machine that uses MRI guidance. So, what we've talked up to until now is we used KV or MV or a CT. But there are some very, very expensive ones out there that use MRI guidance. And there's only a few brands that actually make this. But it's very, very similar to the standard external beam treatments. The machine looks different because it has MRI built into it. So your safety protocols change because MRIs use a very strong magnet. So you can't bring certain things in there. The materials have to be different. There's a lot of safety protocols. One thing that's really nice about this, though, is that we can get an MRI during our scan. So, with our photon beam, we can't treat with photons and image at the exact same time to monitor like a patient's breathing. But in the MRI, you can because the magnetic field is different than using more photon energies. So you can shoot photons that are high energy for the linear accelerator to treat the tumor and also use the MRI at the same time to image while you're doing it. So you can see the patient's breathing and the location of the tumor change as you're delivering that dose, which is super cool. And that's what we call that intra-treatment imaging. So it's within the imaging. We're already doing the treatment. It's happening. One thing that is kind of a downfall is that with these patients, the way that the linear accelerator works, we have to have a CT done prior to be able to calculate how much dose would be given by the linear accelerator to the different structures. So some patients, before they would receive this type of treatment with the MRI machine, they would also have to get a CT and a planning MRI. So they couldn't just get the one, they would have to get both. So that way the dosaging would work out. And that's more on the dosimetrist side. That's not really us per se. But I mean, obviously that's just extra dose for the patient and an extra scan they would have to pay for. So this is still a little bit more rare because it's newer technology. It's fascinating and incredible for the patients, but it's very expensive as well. So these hospitals or cancer centers being able to afford being able to bring that in can be very, very challenging. Proton therapy is going to be an extension off of the external beam by using particulate radiation, but it's looking at the bigger subatomic particle of a proton. So we talked about electrons already. They're much smaller. They don't penetrate as deeply, so they're more for superficial cancers. Proton therapy can deliver its depth much like a photon could. However, it has what we call a rapid dose fall off. So, what happens is the dose comes in, interacts with the tumor, and it almost like just drops off a cliff right afterwards. So, there's basically no dose almost delivered after that tumor. So, that really protects the different structures that are located behind said tumor. But this doesn't work for every single treatment. There's a lot of different cancers out there that they can't do this with, especially because the dose before the tumor is going to be greater than what we would have seen in external beam, just regular photons. Okay. But what's behind it could be much more protected. So just really depends on the person, their cancer, their whole setup. It is very expensive, and it's a little bit more rare. So people were having to travel like states away to get this. Kansas City, was going to be our closest one, and they haven't even had that for that long, maybe a few years at most. So prior to that, they were having to go to, I think Texas was probably going to be the closest one to us. And so that was just a dramatic change for them, and obviously not suitable for them to have to relocate for their entire treatment. And another thing is that insurance was not super great about covering it at first, and I still think that there are some challenges with that. It'll cover it in some instances, and then others, they are saying, nope, the photon treatment was what they should have had, so they may not cover any of it. Insurance is a beast when it comes to trying to do cancer treatment. It's very, very silly and unfortunate. On another note, though, this is what a proton therapy machine looks like. So it's a different setup. Their table is on this arm that maneuvers around in weird ways, much different than what we had seen originally. This is their linear accelerator. Also, just very, very different, coming in from a different angle. Their imaging is different. And then these pictures down here show you the dose profile of each of those scenarios. So with our photon or X-ray therapy, we are seeing here that we have multiple different angles that come in. So here's one angle, here's one angle, if I can kind of get it here. Here's another angle, here's another angle, here's another angle. So we have multiple angles coming in, and you can see that dose is spread out throughout the entire brain. And it has kind of this scale next to it. So the blue kind of leading up into the green is not very much dose. Okay. And then the red and the orange, yellow, those are where the big amount of doses are. So the entire brain was getting some dose from different areas, but not as bad as what the tumor was, right? Then you come over to proton therapy. We only have one beam coming from this location. And we still have green in here. It's probably a little bit higher than what this area was receiving before. And you can see the backside of that beam profile just basically drops off. There's basically nothing behind that tumor for treatment wise. So that can be very beneficial to the patient in some ways. Really just depends on the type of treatment and what cancer they had, what their prognosis is. Are they trying to shrink it before they do surgery? What is the plan here? So a lot of different things they have to consider. Internal beam radiation therapy, also known as brachytherapy, is a very specialized form of rad therapy because we are using ionization from radioactive sources to deliver that total dose. So this is going to require us to be in close proximity to the tumor or the treatment bed, wherever we're at. So interstitial, that means that we are within the tissues of delivering that radioactive source. So we're actually putting a needle through a tissue and inserting that radioactive material. We have intracavity, meaning something like the esophagus, it's a cavity. We would be able to go down the patient's throat and bring that radioactive source very close to that skin, the tissue, the mucosa of the esophagus. It does require more of a surgical environment because, as I mentioned before, you do a lot of times have to do a sedation or some type of localizing numbness, something to go along with that to help make it an easier process for the patient. Another thing with the surgical environment is that if we're going into a tissue, we need a sterile environment so we don't introduce pathogens to the body. Because it is so precise, we're going right into the tumor tissue, there's going to be fewer total treatments, but the time is usually longer. So with regular external beam therapy, it's very fast. Like, I mean, usually patients are in and out in like 15, 20 minutes, and that's from start to finish with them, arriving, getting in, getting situated on the table, doing the treatment, and then leaving. So it's not super long at all. With these, they could be under anesthesia or within the surgical suite for an hour or longer. They do high dose and they do low dose. Typically, the ones where they're within the room and they're putting something into the tissues, that whole very large component, that's usually the higher dose. And then if you were to input like prostate seeds, if you ever heard of those, they put in radioactive seeds into the prostate, which will over time release low amounts of ionizing radiation. So when it gives off that radiation dose, it slowly over time is going to shrink or kill off the cancer, the tumor. So there is a few different types. There's a lot of different types of the radioactive sources they could use, but we could use this for prostate cancer. If you have gynecological cancers like uterus, ovarian cancer, even like cervical cancer, breast cancer, if they want to go within the tissue, they can do that. They have done eye cancer treatment as well. So some having to go within the eyeball, others they're able to kind of work around the eye or just press it onto the eye. And then head and neck cancers, again, either through the tissues or in the cavities, where they're able to introduce that radioactive source. Here we have a zoomed in version of our brachytherapy suites. So over on the left-hand side, you can see that this table does have the capability for stirrups for the patient. So if you have gynecological cancers or a prostate patient, they're able to lift the legs up and out of the way so they can access the region they need to. You can see they have tons of storage throughout the room. They even have a sink involved. Kind of just depends on what your facility offers for space wise and also what the physicians need to get the exam done. Over on the right hand side, this to me looks more like a surgical suite because it reminds me of it with the ceiling mounted lights where the physician can reach up and grab this little component here or this little handle here and maneuver that light so that they can see better. They do have a mannequin on this table, and what's interesting about this one is this is a suite that has a built-in CT. So the CT is on rollers. So when they're ready to image and ensure, like if they're putting in prostate seeds, that they're at the correct location or just verifying where that radioactive source is, they will bring it this direction. And so the whole thing will slide, and you see how the table is completely empty underneath? That allows for the patient to actually move inside of the gantry of the CT machine. So they're able to localize everything and see what's happening. Here we have a couple examples of brachytherapy procedures. The left picture is going to be a breast cancer patient, and they are doing it interstitially where they have brought these catheters into the tissue, and you can actually see kind of faintly on the skin where they have this blue circle and then blue crosshair. So that was indicating where that cancer lesion was located. And so what happens is they will push those catheters through, and once they push them all the way through, the catheter sticks out on the end, and then you can see there's like a little button at the end that helps close off the end of it. It's like a cap. And so then at the open ends of the catheters, which are going to be outside the body, somewhere over here, they can then put in the radioactive source through the catheter and it will go to the depth that they need it for that tumor. On the right hand side, this is going to either be a gynecological cancer or it could be a prostate patient. They have the stirrups, so this is part of one of the stirrups. And so then their legs are lifted into the air and out of the way. This is the radioactive source device that houses all of them, and the sources are placed and they come through the catheters through here, and they will come up and they will go inside the patient. So it looks like this one's probably more of a gynecological cancer, and so they're able to insert it into the patient, and then they will obviously put in the radioactive source, leave it on for a certain amount of time to deliver a certain amount of radiation, and they will remove it from the patient. So these are very invasive procedures compared to our external beam, but it can provide potentially greater treatment options for certain types of cancers. So, not everyone is going to qualify for brachytherapy, and not everybody even has access to brachytherapy because they have to have the surgical suite, have to be in a certain location. So, not every place will have this. Here we have an example of our seed implant for prostate cancer. And so on this diagram over here, we will have to go from the lower portion of the patient. So they're going to come in from below the pelvis. They can go up through the rectum to place those prostate seeds, or they may just go through the tissue that sits right outside of the patient, external to that prostate. And so when they place those, you can see where the prostate is, and then all of the little, they almost look like little beads, but they're little seeds within there. And if you're curious about the actual size of prostate seeds, they are over here comparatively to a penny. So all of these are prostate seeds, and they're very, very tiny. These will stay inside the patient to deliver a certain amount of radiation over a period of time. Once they have reached that limit, they become inactive, and so they can just stay inside the patient. It's not going to affect them any other way. They're not even going to notice that they're there. We have numerous people that are involved in our whole process for treating cancer. So we have a radiation oncologist, we have radiation nurses, a dosimetrist, a physicist, a dietitian, social worker, and then obviously radiation therapists. There are some other kind of external ones that may be kind of rotating throughout if necessary for the patient, but these are typically the ones that have the most direct contact with the patient, usually. The radiation oncologist is a physician that has been trained to treat the pathologies with radiation therapy, and they're going to oversee all of the care for the patient. So, regardless at which stage that they're at, so if they're at the beginning for their consultation, if they are currently being treated, if they're still in a simulation process, whatever kind of component they are, facing at that point, they are the person that oversees all of it. They're going to meet with the patient at the very beginning for their consultation to discuss their radiation treatment and their options. And they have to go over all the benefits and the risks of doing each type of procedure. And they will also write a prescription. So, much like how doctors can prescribe you an antibiotic or a steroid, the radiation oncologist will prescribe a certain amount of radiation for that location. And then they will also decide how much they want other anatomy to receive, because the healthy tissue surrounding your tumor is going to get some radiation. And so they determine exactly how much is acceptable for those regions. The radiation oncology nurses are nurses that are just more specialized into our radiation area. And so they are going to evaluate the patient's well being over their entire journey. So even from the very first time that they meet with the physician at their consultation, they are going to do their vitals. They're going to ask a lot of questions, keep their chart up to date. And then when the physician meets with the patient every week to see how they're progressing, the nurse is going to be with them as well, again, to take vitals, check their weight, how they're eating, ask lots of good questions. They do a lot of the communication with them. They also can send prescriptions to pharmacies if the physician decides that maybe this patient's in a lot of pain from their treatment, especially if it's a head and neck patient, their throats can get very, very sore, and it makes it really challenging for them to eat. So they can send off for a pain medication to a pharmacy. And so the nurse will work with that to input all of the prescription that the doctor had and make sure everything goes through. They can't administer medications as needed. So if they, for some reason, need like a booster shot of something, um, sometimes they'll come in and they'll get like their flu shots and things like that from like our area if it's that time of year instead of making them go to a different facility. They also are going to work with all of us healthcare professionals to provide patient care. So if they hear something about the patient, they can communicate with us saying, hey, it seems like they're not getting around as good today. just giving you a heads up before you start treatment, or if they know that the patient has not had enough to drink for their prostate treatment and they're going to need to have a full bladder, then they can, again, communicate that with us. So they are a great liaison for kind of all areas to help us make sure we have great patient care. The dosimetrist is going to be a specialized person that is in charge of creating treatment plans. And those are going to be based on the radiation prescription that the doctor created. So the dosimetrist takes it a step further and they look at the prescription, see how much dose they want to the tumor as well as the surrounding structures, and then they go to work with some software. The software is going to help them create their treatment plan and see what the options are. So, can they do 3D CRT? Can they do IMRT, VMAT, or IGRT? Just looking at it and deciding what is needed for this patient. And then they'll work with this software to help them create it. It's truly a process because they have to input all the information, they have to go through the different beams, see which angles can the tumors come in at, all of those things. So here's some example of the software. So when you input the information, and so it'll highlight the volumes that the doctor has drawn around these structures. So when they're trying to identify where the tumor is and how much dose they want. So over here, this is a very, very large area that they are planning on treating. And so the red means that it's getting a lot of dose. And so they have made sure that with all the different angles that these beams are going to come in, that it meets a certain threshold. And so that will actually be written out on a graph, which we will discuss further within this course. But they're trying to make sure that they're getting enough dose to the tumor to actually kill the cancer cells, but also not enough dose to the surrounding areas that it's going to cause major issues. You can see that down here as well for a brain cancer patient. So it's actually showing you down here as it's the beam is going through the patient how much dose they would be getting and as it's going to be rotating around them. Here you can see where the volumes were drawn on the patient to indicate where that tumor is located and then the areas surrounding that they're okay with their being dose delivered to. And then a prostate patient over here, you can see there's going to be multiple beams. So they're going to have a beam that comes from this direction, this direction, this direction, and then a couple coming from the front. So 5 different beams there, and they're all going to be delivering dose to this area within here, which is going to be that prostate. And so then all of the other kind of drawings around there in different colors indicate how much radiation dose would be given within those structures based on those beams. So it's truly a process for them. Sometimes they make 5 or 6 different plans and they all get scrapped because there's too much dose to an important structure or the tumor's not getting enough dose. So they really have to be creative with this. The software does help them, but it's a lot on their ability to use software. It's kind of like Excel. Excel has a lot of capabilities for you to type in information and perform formulas, but just because it has capability doesn't mean that the user knows how to use it. So if you're not very good in Excel, you're not going to have a great turnout for what you could produce. Versus if you are very proficient in Excel, then you have kind of unlimited possibilities. So that goes to show you as well with using this specialty software for dosimetry, that dosimetrist needs to know how to use it very well in order to give the best possible treatment plans. A medical physicist is going to be someone who specializes in testing and evaluating medical imaging equipment. And so these ones typically stay within your physical site, or they may have a couple sites that they oversee. Um, as far as like X-ray, CT, all of those, they have somebody that comes in and tests those annually. So they have a physicist that may rotate around to multiple different states just doing annual testing. But for radiation therapy, typically you have one on site or between a few sites because they have to do your quality assurance and quality control on every patient's imaging and all of their individual plans. So they can't stray very far because if you have new patients starting every day, you need to be able to have them run through that quality assurance and quality control. Plus, they have to do at least monthly testing on other things with the machine as well. So they'll be doing a lot of different evaluations on the machines and treatment plans. So you may get to know your physicist fairly well. I mean, if they're interested in talking while they're working with things. So I know the one that I was with at my clinical site. Her name was Sapita, and she was amazing. She walked through everything on how they did all of their processes, and they typically just have an extraordinary mind for all of like the numbers and all of the theory behind everything, how it all works. It's incredible. So they have a ton of knowledge behind that. A dietitian is going to be a healthcare professional who ensures that patients are able to have healthy eating habits and are maintaining weight or goals within their diet. So we do have some issues with this in radiation therapy because patients, especially that are being treated in their gastrointestinal area or their head, neck, kind of esophagus region, they may be experiencing a lot of pain or discomfort, and so they tend to shy away from eating because it's painful for them, it's not enjoyable. And so we don't want them to lose weight during our radiation therapy treatments because if they lose weight and they lose fat. And that fat or the body changes, the physical changes, will change where that tumor is located. So if they lose a lot of weight, we may actually have to completely start over and re-simulate them and then kind of go with the prescription and see where they're at radiation wise and make all new immobilization devices, start over. So that way we are ensuring that we get the correct amount of radiation to that tumor. So our goal is to help them eat because eating is important and to maintain that weight. So the dietitian can come in and suggest some diet changes. Do they need to be drinking more liquids? Can they, if food's too hard for them, can we get them some protein options like protein shakes, things that they might actually want to eat? Ways to help them take their medicine if it's too painful. Can we get them a liquid medicine instead of the pills? Um, just a lot of different things to help them be more comfortable throughout it and make sure that their weight is somewhat maintained. A little bit here and there is not a big deal, but drastic changes will make us have to start over. A social worker is another important person on our healthcare team in radiation therapy because our patients are going to need support and that may need connections that we as therapists do not have or that nurses or the physician don't have. So a social worker will be assigned to each patient and their job is to meet with them and figure out their situation regarding their home life, mental health, what their support system looks like, even things like transportation. So, as you know, we have treatments that can last up to 6 weeks every day. So, how does a patient get to us? If we have patients riding a bus for an hour, you know, that can be challenging to ensure that their time frames for treatment line up with the bus schedule. So they're going to be a good liaison from the patient to us as well to see how can we make this possible for the patient? Can we be flexible to maneuver their time around so that they can take the bus? Or if they have a family member that can drive them, how do they have, just good transportation to us? Mental health wise, if they need like counseling services, they can get them in touch with them. More things like how can we help their home life? Is there anything we can send home with them that they may need for like a daily necessity? So they have these resources for patients that we don't have, but that the patient desperately needs in order to make sure that they have the best possible care. And of course, we have our radiation therapists. And so our job is to safely and accurately deliver our high energy radiation treatment to the patient. We are also responsible for scheduling our patients for their daily treatment times and if they need to come in for simulations, anything extra they might need. We communicate with all of the healthcare professionals. So we talk daily with the physicians, the nurses, social worker if needed, dietitian, dosimetrist, physicists. We have to run what we call quality assurance and quality control checks on every single patient's procedures or treatments that they're having. So we have to make sure all that works well. We do our daily treatments on our linear accelerator, but we also use our CT machine for simulations. And so we'll have to do warm up procedures and shut down the machines, do any kind of checks daily on those. We have to perform the simulations in CT. So we will take a break from the linear accelerator and go over to our simulation and do that whole process, get their mobilization devices created, electron blocks if they need to. We can get them completely set up and things organized for their first day of treatment. We also have to provide high quality patient care. So we are a huge advocate for our patients, and we can talk with them every day and try and make them not think about the fact that they're coming in for their treatment, but more, tell me more about yourself or your kids or your, dogs if you have pets. Have you gone on any like vacations, trips? What are some of your future goals? Just like literally anything to get their mind thinking positively instead of on the negative side effects of treatment and everything that they're going through. Even if the patient's not very talkative, but just saying, "Hi, how are you? And how's your day going?" Things like that. Putting a smile on your face then also can reciprocate and improve their mood. We also have to maintain a detailed patient record of everything that we do. Patient up, what their distances were, if we're trying to take pictures of the setup, all of those things. Over here, we are going to have our treatment console. So we sit behind here. That is our daily place to sit. We will monitor the patient through the audio visual, and then we will also deliver the treatment. We will do our imaging prior to that, ensure everything lines up correctly, ask the physician if we have any questions, all those things. Here we have a couple pictures of setup. So typically there's going to be 2 therapists per machine. So that way you have somebody else to help you, especially with lifting or moving patients, because you will be moving them around quite a bit to get them in the right position. And there's usually a lot of pieces that are necessary to get them where they need to be. And then up here, you're going to line them with the lasers to ensure that they're in the correct location before you start imaging and then treating. Here's a very brief overview of looking at our planning process because throughout this semester, we're going to look at every individual component here. But we're going to have our consultation where our physician meets with our patients to discuss their treatment options within radiation therapy and anything like benefits versus risks, side effects they might have. Then, if they agree to that treatment, they will move on to imaging, which is our simulation. So they'll go to CT and we will image them in the position that we expect them to be every day for treatment. And we will make immobilization devices to help them maintain that position. We then will move on and send those images from simulation to the dosimetrist where they will do treatment planning. So the physician and dosimetrist will help create the treatment plan based off of how much dose they want it to receive and which angles the beams are going to come in at. Then we also have to do some quality control and assurance before we can treat the patient. But that very first day, we are going to see that the patient will come in, we'll get them all set up, show them the machine in our area, align them correctly, make sure that we have our marks, and if we need to reposition slightly, we will image and ensure correct position location before we actually deliver that treatment that day. And then every day from there, obviously, they will be treated out for their extended amount of exams. And then we will, once they're finished, have a follow up with them. Typically, that can look about like 3 or 6 months, depending on the patient and if they had major side effects or if they expect possible reoccurrence of the cancer. So that's kind of the process from start to finish. But up here is what we're going to cover throughout our uh, semester here specifically. We'll talk about consultation, simulation, creation of our plan, quality assurance and quality control, the first day of treatment and all the items that go along with that, and then things that we have to do weekly to ensure proper patient care. So, with patient care, it's extremely important in all fields of healthcare. However, in radiation therapy, it is crucial because they're going through one of the most challenging times in their entire lives. And cancer itself is scary, but also the treatment and the toll it takes on their body is hard, and it's a scary process. So as therapists, even though we are not a true like therapist, like a psychologist, but we are there to help be an emotional support for them. So we can listen to them and provide them with information or resources, or connect them to the social worker or the dietitian as necessary, or get the physician or nurses involved. We have to use empathy for them. So we never want to use sympathy. We're not, overly sorry that what's going on in their life, but we're trying to say, we know that you're going through something, and, we want to do the best that we can to take care of you. Because if you're on that version of sympathy, you start to actually take on some of those feelings, and it can be very, very challenging as a therapist, to constantly have that mental load and emotional load. So having empathy is a little bit more objective, but it still allows you to tell the patient that you understand what's going on, and you're going to do the best that you can to give them the best care. And always having a positive attitude is a huge thing. I think we've all probably worked with some people that may not have the best attitudes every day. And while, yes, everybody's allowed to have a bad day, like that's always going to happen, we're human, it's really important that you don't let that go into your work in healthcare, especially in radiation therapy, because the patient doesn't need that extra mental load and emotional load that you're giving them by not being there for them. So leaving all of that extra stuff at the door and having a positive attitude, smiling, having a listening ear, regardless of what's going on in your personal life, because it makes a huge impact. I'm not going to lie to you, because my mother went through breast cancer, and just her talk about the therapist and what they were able to do for her just by having a positive attitude was a huge impact. And so many patients feel that way. When I was in my clinical experience, we had so many patients that had been treated 6, 8 months prior that would come back when they were coming back for a follow-up appointment, and they would bring candy, cards, chocolate, flowers, because they were just so thankful for the role that we played in healthcare for them. So very, very important to think about that. And if patient care is harder for you, maybe this could still be a possibility for you, but maybe consider that this could be a very, very challenging portion of being a radiation therapist. Patient care can also be obviously a very physical job, right? And so I think most of us already know that because of working in radiology. So there's a ton of us having to lift or move or transport patients, and we still have to do that in radiation therapy. And especially when we're trying to help them maneuver and position on the table, we do have to do a lot of lifting. So when you raise your patient up into the machine, I'm only 5 foot tall, so they're at like my shoulder level. And so with that, when I have to roll a patient towards the other side, sometimes I have to get up on my tiptoes in order to kind of roll them or slide them a little bit different way. It still works for me. So even if you're as short as I am, that's all right. But definitely it takes a toll on your body after all of the maneuvering around. You may have to do total lift patients that are paraplegic or quadriplegic, helping them on the table with the lifts. That can be, challenging as well. At least the lift helps do most of it. But we may also have to have patients help them use the restroom, or helping them with personal items and things while they're in the room with us. So just because we're kind of more of a clinic setting doesn't mean that we don't have some of the same healthcare responsibilities that you would in a hospital. Um, and many times emotional and physical things are happening at the same time. So they could be telling you a really, really sad story about what's going on in their life and what they're going through, how much pain and suffering they've had, while also trying to lift them and maneuver them on the table. So it's kind of coming at you from all angles, but you get in a mindset of you're really helping a patient. And so these things over time, just they don't seem to build on you or burden you as much as maybe in the beginning trying to figure out that balance. But it's such a rewarding career that so many people stay within this. It's a great career field. And so I don't think that, while I say that emotional and physical components are there are stressors in our field, it's not something that I want anybody to look at and say, oh my gosh, I can't handle this, because I think there are a lot of people out there that would be amazing at being a radiation therapist. So, just some things to kind of think about with this career. Some qualities that I think make a very strong therapist is that the patient and you have to have a relationship. So you need to have compassion and empathy for our patients in order to be successful. You also need to be very detail oriented because we are going to be moving centimeters to millimeters to be very, very accurate. So, staying organized, knowing what you're looking for, seeing discrepancies in numbers or things that are slightly amiss are very important. Time management is also crucial because you are going to have your patients as a set schedule. So you are going to have 15, 20-minute time slots, maybe 30 if it's a new patient starting that day. And so you have to stay on time while also, making sure that patient gets everything that they need and they feel like you are having empathy for them. So, time management, trying to work while also chat, while also trying to schedule patients and do your actual whole chart check. And there's just a lot of things that can happen at the same time. So, time management is important. Interpersonal skills, so that actual communication and working within your team. So, chatting with your physician, your nurses, the patients, dietitian, dosimetrist, physicist, your other therapists. It's very important. Teamwork. You're always going to have another therapist that you're working with. Um, I don't know of any place that has one therapist. And if they do, it's very, very frowned upon to do that because you want two sets of eyes on everything. So working with your teammate, your other partner, your therapist, or working with anybody else within your healthcare system is extremely important because if you hear something about a patient, they're saying that they're in a lot of pain from this, you need to communicate that with the physician and nurses so that they can then decide, okay, does this patient need additional pain meds? Is there anything we can do to help make them more comfortable? And then also technical skills. So you do have to use the computer. You have to know how to use the software, which you'll learn. They don't expect you to automatically know that before you start school, and how to navigate through electronic medical records, input things, and then also again with going back to that detail oriented, checking numbers, making sure that everything lines up correctly, using that hands on component and aligning as best as you can. So, those are some strong qualities that I would be looking for a therapist.